Thank you. So the topic of my discussion is PIRADS for RADONCs, a multidisciplinary educational lecture to improve prostate MRI interpretation for radiation oncology residents. My name is Ebenezer Asare, and I'm a PGY3 at the University of Virginia. Why PIRADS? So MRI imaging is often utilized for radiation treatment planning. Prostate multiparametric magnetic resonance imaging are increasingly utilized in the staging and characterization of prostate cancer. However, a majority of graduating radiation oncology residents, according to one survey, do not feel confident by the time they graduate about their imaging education, and only about a quarter of programs have radiation or radiology anatomy didactics. In the era of hypofractionation and focal dose escalation, such as the FLAME trial, where an additional boost of radiation was given to the dominant intraprostatic lesion and showed an improvement in biochemical disease-free survival, highly accurate target delineation is necessary. The prostate imaging and reporting data system was designed to improve detection and risk stratify patients with clinically significant prostate cancer, and is a useful scoring system for radiation oncology residents in training to understand. Though imaging interpretation is an integral part of radiation oncology, formal education is limited. Our aim was to create an educational lecture with radiology colleagues to increase knowledge and confidence with MPMRI and PIRADS. So we created a 45-minute lecture summarizing the American College of Radiology PIRADS document, which can be found online. And there was oversight provided by genitourinary radiology colleagues who are fellows and a radiation oncology attending who specialize in the treatment of GU cancer. We assess knowledge and confidence with a pre- and post-lecture questionnaire. Our lecture covered MPMRI image sequences and the concept behind them, as well as their interpretation. We covered normal prostatic anatomy and how both of these factor into PIRADS scoring with examples. One example is shown to the right. This shows a PIRADS lesion, and on the left, we see a T2 weighted image of a PIRADS lesion located within the peripheral zone, which is hyperintense. And on the right, we see the corresponding high B value DWI image. Residents from 3 institutions attended the lecture, both in person and via WebEx, and a radiology fellow and radiation oncologist who specialized in GU cancer was available to answer any questions. We measured confidence by using a Likert scale, 1 being no confidence and 5 being the most confidence, and that was for a total of 10 questions. And the knowledge assessment consisted of true, false, dichotomous, and multiple choice questions for a total of 12 questions. One example of our knowledge assessment question is shown here, where we would give a brief history of the PIRADS lesion. Here we see a T2 weighted image of a PIRADS lesion that is located in the anterior part of the transition zone. It's 1.1 centimeters in diameter, but this is a PIRADS 5 lesion given the fact that it has extraprostatic extension, whereas normally a PIRADS 5 lesion has to be greater than 1.5 cm. We had a total of 13 participants from the 3 institutions, with the breakdown shown here. And this was across multiple PGY years from 2 through 5. And we had a high rate of completion of 85% of the post-test survey, post-lecture. So what did our results show? In terms of confidence, we saw as expected that confidence was very low, where the average confidence was 1.9 out of a 5-point Likert scale. And confidence significantly improved, more than doubled post-lecture. And you can see on the right in the interquartile range box and whisker plot showing this data. For knowledge, we see a similar trend where the pre-lecture score was low at 58%, but this improved by 25 points and was statistically significant post-lecture. So in conclusion, hypofractionation, focal dose escalation, and new imaging technologies such as the MRI linear accelerator require highly accurate target delineation. However, most radiation oncology programs do not have dedicated radiology didactics. This lecture was able to show that imaging interpretation could be improved for MPMRI and PIRADS. And concise lectures similar to this, with participation of our radiation or radiology colleagues, focused on imaging modalities that are most important for radiation treatment and planning, can improve knowledge and confidence in trainees. Some of our future directions include assessing the retention of knowledge at a later time point, assessing, of course, a larger sample size at more institutions, and we would want to create an online learning module that could easily be given to multiple institutions aimed at radiation oncology residents. And ultimately, my goal and the other authors is to create a RADS MRI lecture series that covers a variety of MRI topics such as LIRADS, PIRADS, and any disease site where I think that we need more comfort to be able to treat patients using this imaging modality. I think we need to continue to strengthen our multidisciplinary partnership with our radiology colleagues, and this has shown benefit at one institution. I believe it's at UCSF. They have dedicated radiology rounds, and this has been shown to change their tumor volumes more than a third of the time with high satisfaction rates. And with that, I'd like to thank my co-authors at UVA, Dr. Janowski and Dr. McLaughlin, and the radiology fellows, Dr. Jesser and Dr. Kazuz, Dr. Lumine, as well as the medical student and bachelor. Thank you.